Great. I won't take much time, but just to tell you all who I am, I'm Sumegha Asthana. I'm the co-chair of the working group representing women in global health, and I'm the co-founder of the Women in Global Health India chapter. I am in my day job a policy researcher and a health security researcher at the Center for Global Health Science and Security at Georgetown University. And I'm joined by Rosemary Mburu today, who will also introduce herself shortly. We also have our wonderful speakers, Elo Otobo and Jackline Kiarie, who will also be introduced very shortly. So today's meeting, we're focusing on political declaration of United Nations General Assembly, high-level meeting on pandemic preparedness and response. But before we begin, I'll just take a few minutes to share with you a few highlights from our last meeting, the second meeting on June 6th, where we discussed gender issues within the international health regulations and the international negotiating body processes. We were joined in this meeting by Dr. Claire Wilhelm and an academic expert from LSC who's working on global health security and global health governance, and also by Ms. Kim Sales, who's the co-founder of Women in Global Health Philippines chapter and is actively involved in promoting gender equity. Both speakers shared their insights on pandemic prevention and the IHR, and Claire highlighted that gender has been addressed at only 2 places in IHR 2005, but things are changing. But still, she shared how gender was still poorly taken into consideration in the 300+ IHR amendments submitted by the member states last year. She shared that the focus has been mainly upon representations within the committees, and the exclusive focus on representation in IHR and the INB drafts is particularly problematic. It should go beyond representation to have more meaningful engagement. She also shared that getting the gender on the instruments will only happen with the CSO's engagement and advocacy. And Kim also stressed on the same meaningful representation, but she shared 3 solid points on the meaningful women's engagement, where she said the impact will follow through CSO's role in the advocacy and coalition building, and also through more of evidence-informed advocacy. And she stressed that the use of evidence will make a more compelling case for a stronger gender language. Thirdly, she stressed on including the voice of the people with these lived experiences if we want to move forward with this agenda. But for today, I'll just take a pause here and give it to Rosemary to introduce herself and move on with the agenda, and I'll see you shortly.
Yeah, thank you so much, Sumegha, for the introduction. It's a pleasure to be here and to participate in this working group meeting. It's my first gender in PPR working group meeting, and I'm excited about the conversation. We have amazing speakers lined up for today. And I just wanted to, first of all, introduce myself. My name is Rosemary Mburu. I serve as the Executive Director for WACI Health. We are an Africa regional advocacy organization. I'm based in Nairobi, Kenya. And we've been working and engaging on the UN high-level negotiation preparation in the lead up to the actual meeting. And it's a pleasure to see a meeting dedicated to thinking, reflecting, and having a conversation around gender considerations within the PPR outcome document. I think for me, one of the things we were told during COVID-19, especially for our continent here in Africa, is that community health workers were the guardians of our continent during that pandemic crisis situation. And thinking about community health workers and recognizing that a majority of them are women. And so the conversation of how do you have such a workforce among community health workers who are on the ground with so much expertise, experiencing the day-to-day challenges, being themselves, in the front lines, but not having the ability and the access to decision-making platforms, to decision-making boardrooms, to actually input into process where that is needed, I think is a missed opportunity for the global community when it comes to how you manage, how you prepare, how you prevent pandemics. And so it really is a pleasure to have this conversation. And I'm going to introduce our first speaker for today. It's my pleasure to introduce Elo Otobo. who is a global health expert in advocacy, policy, and program delivery in low and middle income countries. She is a senior health advocacy and policy advisor at Save the Children UK, where she leads the portfolio of women, children, and adolescents' health and sexual reproductive health and rights. She is also the technical lead for global health partnerships. She represents Save the Children on PMNCH Strategic Advocacy Committee, which is the UK SRHR network, and co-chaired the UK Maternal and Newborn Health Working Group. Previously, she has driven programs in Madagascar, Sierra Leone, and Ghana, improving direct health service delivery to pregnant women and adolescent girls. She has considerable experience in maternal service delivery and access to SRHR and family planning for adolescents and youth. Thank you so much, Elo, for joining us here in terms of sharing with us your expertise, your thoughts, your reflections. And so I'll hand it over to you now to give us a brief intro, including an overview of your work, any relevant background you have relating to the UN-HLM negotiations, and an overview of how gender and issues of gender equality are being addressed in the current negotiations. Over to you.
Thank you, Rosemary. I'm just going to share my screen now. And please just confirm if you can see the screen.
We can see it.
Yes, it's here.
I'm really thrilled to be with you all today, and thank you for inviting me to speak. I'm really, really honored to be speaking today. So I'm here to talk about really why all efforts to build stronger and more resilient health systems must be gender transformative. By this, we mean that achieving the state of equitable access to resources and opportunities for all people, regardless of gender, including economic participation and decision-making, and the state of valuing the different behaviors and aspirations and needs equally, regardless of gender. And to ensure equity, we really need to put measures in place that compensate for the historical and social disadvantages that mean some groups are not operating on the same level field and some groups are more vulnerable to social exclusion. So this is going to come of known news to all of us, but the pandemic was really one of the most disastrous global health incidents in the recent decades. It caused whole of society devastation. We saw economic and social disruptions, millions of lives lost, exacerbated multidimensional poverty, food insecurity, a strained civic space in many countries, increased violence, and importantly, a mental health pandemic, particularly amongst adolescents. So it really highlighted how fragile our systems are, particularly our prevention, preparedness, and response architectures. And we saw that WHO has estimated 14.9 million excess deaths, 2 billion people currently facing catastrophic health spending. And the reason you could say that we had these impacts, we were not well prepared to respond, is because the existing inequalities in our societies meant that there was no equity and resilience. So whilst we can all say we've all experienced quite a lot of trauma over the last few years throughout the pandemic, it's certain that some people were able to protect themselves and had more resilience and social protections than others. So we can't really talk about the issue of inequality without touching on gender and also intersectionality. So when it comes to women, women had that double burden of care, looking after the domestic and social care, both in the community, but also then the unpaid domestic care that they do in the homes, combined with the paid work that they're doing in society. So we know that primary healthcare, however, can be a cornerstone to achieving UHC, and UHC can be the way in which we can better prepare for future pandemics and emergencies, with the potential of saving 60 million lives and so on and so forth. So I'll quickly move on to this concept of a shadow pandemic. We also experienced in COVID-19 an increase in violence against women and girls. We know that during health emergencies or when there's social and economic stress, women are often more vulnerable to violence from their male counterparts and others who would do them harm. Similarly, girls had a similar experience of increased violence against girls. We saw early in the pandemic a hike in teen pregnancies due to school closures. When girls no longer have the social calendar or they're not able to access school, they become more vulnerable to sexual exploitation, abuse, and again, those who will do them harm. When girls have lack of economic access or when they need other sort of resources, again, they can be really vulnerable to exploitation. And we saw that through the pandemic. coupled with the fact that a lot of essential health services were closed. Essential health services like family planning, like maternal and newborn child health services, like counselling services, closed due to the lockdowns. And then you have women and girls more exposed than they had been when these services were available. I've touched already on the double burden of care. And I heard the earlier speaker, both Rosemary and Asthana, mentioned that women are over 70% of the global health workforce. They are very much involved in the front line in community care, yet they are less than 25 when it comes to influential decision-making roles in the global health architecture. So we have already a disparity of care. Women are also more likely to be in lower paid works, lower paid service jobs, which we saw in the pandemic were increased risk of social and economic stress. So if you're in a job where you don't have economic stability, where you don't have the savings to protect your family or yourself, where you can't decide how to reduce your exposure to certain risks, we saw a lot of essential healthcare workers at increased risk. And again, we can't talk about these issues of inequality without talking again about intersectionality. This is the idea that certain groups are more exposed to risk due to structural inequalities. So these could be things like housing, access to food, food security, mental health access, education access, financial resources, access to green space. For many of us in the pandemic, access to green space was one of the ways of protecting our mental health. And you can imagine if you're living in high density housing, you're unable to reduce contact with other people. How can you protect yourself in a context like COVID pandemic? So for Save the Children, we really believe that the actions have to be grassroots to global. We have to adopt a whole of society approach and develop these strategies that work across ministries, because the pandemic wasn't just a health incident, it was a global incident across many of our sectors, and in fact, our entire lives. And to achieve this, then we need good governance and accountability. So we need success that's driven by meaningful civil society engagement. And we need leaders to see civil society engagement as an asset, something that can put them on the right track, support their policies and support implementation. And to achieve this, we need financing. So we need increased public investments and allocations, particularly for primary healthcare. And we need donors to be paying their fair share. You know, in COVID, we saw a lot of vaccine hoarding in the beginning of the pandemic, bilateral deals ongoing outside of the ACT-A body. So we need fair donors to pay their fair share and act fairly. And finally, PHC is also the cornerstone. I've mentioned this before, but community-based primary healthcare must be recognized as a key strategy in improving our health outcomes, particularly for children, but also in response to emergencies. I'm going to quickly talk about the history of the political declaration. So in 2021, the independent panel really called for greater political leadership when it came to response to emergencies. This led to a resolution being adopted in September 2022, where world leaders agreed on hosting a high-level meeting on pandemic prevention, preparedness, and response. Israel and Morocco have been selected as the co-facilitators. And earlier this year, there were multi-stakeholder hearings where even NGOs were invited to make comment on the political declaration document. Between the 5th of June and the 26th of July, this document is now going through a series of negotiations where member states and civil society are negotiating and engaging on what language will be in the final document. And then on the 26th of July, it will be put under silence procedure to be adopted at the UN high-level meeting in September. It's important to note that there will be a session. The high-level meeting has a theme of making the world safer, creating and maintaining political momentum and solidarity for pandemic prevention, preparedness, and response. And there will also be 2 panel events focused on governance accountability for PPPR and also equity through capacity building. Now, the high-level meeting was broadly supported by lots of member states. It was co-sponsored by 12 different member states. And the purpose, although it's occurring in alignment with the international negotiation body decisions around the IHR, it's a separate process that's looking just beyond the health system alone and looking at wider social and economic facilities that impact pandemic preparedness and response. I'm also going to share with you a little bit more of a detailed timeline on the negotiating process. So today and yesterday, the revision 1 of the document is currently being negotiated by member states. And that other image also shows to you the timeline. So again, it's just in more detail. Now, just to go through some of the language that we've seen in the first draft versus the revision 1 draft, we were really thrilled to see a recognition of the role of healthcare workers. We've already heard earlier in the call today, and I've reiterated it, the importance of community health workers in responding to any emergency. And we've seen that language is supported in the first draft and the 0 draft of the high-level political declaration. There's a recognition that decent and safe working environments is crucial for community health workers and frontline health workers to respond adequately to any health emergency. There's a recognition that training, investing in health workers and retaining a skilled health workforce is a crucial asset when you're thinking about resilience in your health system. There was also a call for equity, social justice, and social protection mechanisms. Again, thinking beyond just health and thinking about the other wider societal issues that we were all tasked by during the pandemic. There's particularly mention of clear vulnerable groups, those who are most vulnerable to social exclusion and marginalization, or those most impacted by poverty and other issues that could marginalize them from health systems. So we have there the mention of those who are internally displaced people, people living with HIV and AIDS, youth and young people. There's a particular recognition of the role that women have faced during the pandemic, particularly a mention of the issue of equal pay when it comes to female health workers. And that's really crucial in recognizing, again, the impacts that women faced during the pandemic. And finally, but certainly not least, there's a reiteration, a call to member states to ensure that the rights of women and girls to employ the highest level of health, particularly with sexual reproductive health and rights, is in accordance with the ICPD program action, is reiterated and reaffirmed. So at Save the Children, we were really thrilled to see some of this language. But in this, you'll see in revision 1, the negotiations have gone even further. We've seen a bit more specific language around exactly who we mean, a stronger view of intersectionality. By that, I mean there's a mention of people of African descent, noting where the need is the greatest, also mentioning the need for donors to ensure resources are made to support Africa's efforts to prevent, prepare, and respond to outbreaks and epidemics. Again, noting more plainly exactly where the greatest need was during the pandemic. There's also a strengthened recognition of women's full, effective, and meaningful participation in leadership, the need for women to be in leadership, and a recognition again of the gender pay gap. There's a call to action on social justice and social protection mechanisms. So you can see in the revision 1 already, the language is extended. When it comes to groups of marginalized, or those who are most impacted by social exclusion and marginalization, there's an expansion of that remit, noting indigenous peoples, people living in rural areas, women and girls, again, talking about comorbidities, recognizing again the importance of women health workers and the role that they had in the pandemic, but noting also the exposure to increased violence and harassment in the workplace. Mental health issues. So we're seeing like a strengthened language as the revisions are ongoing, and more direct language that's really naming exactly what we mean. So for Save Children, we're really thrilled to see the negotiations moving in this direction. So how is gender reflected in the Zero draft? Well, more broadly, there's a call to action on equity. There's a recognition of the roles and needs and vulnerabilities of women and girls. There's the call for strengthened role of leadership for women, and particularly a mainstreaming of gender perspective into all policies. The declaration reaffirms the need for member states to meet standards set within ICPD on SRHR, which is crucial, as we know, particularly in times of emergency. There is a bit of an intersectional lens, looking beyond just gender, looking at all the other characteristics that might impact a person's access to health services and access to social protection. Gender broadly is seen as a binary in this document, and if we're thinking about where the language on gender has gone, we know that our understanding of gender is broadened, but in the document it still is very much at a binary level. And marginalized groups, including LGBTQ people, men who have sex with men, sex workers, they're nominally excluded from provisions in the document, but you could also argue that they are masked within broader remarks, language like those who are vulnerable or in vulnerable situations. So what has Save the Children been doing to influence this language? Well, we work directly through our New York and Geneva advocacy offices. We work directly with permanent missions at WHO and UNGA. We have been attending and responding to CSO consultations, ensuring that internal messaging is derived through all our technical leads, so bringing a multi-stakeholder perspective to our inputs to these CSO consultations. We're really trying to engage and continue to engage on coalition-led advocacy. So we work through UHC partnerships, for example, the Civil Society for Human Rights in the Pandemic Treaty, HIV and AIDS Alliance, and an informal working groups in Geneva and New York, and through political mobilization. So we work to build consensus, working directly through political channels. In the UK, we're working closely with the FCDO, disseminating key messaging, but also working through multilateral partners like the WHO and other networks like CSEM. So I just want to share with you, I do want to note that on SRHR and on gender, it's clear that in 2023, we're working within a very different context than we were in 2019. We are working in the context of the aftermath of COVID, the war going on in Europe, the rollback of rights of women and LGBTQI people around the world, increased suspicion of institutions, vast polarization in the public sphere, meaning that there's a lot of distrust going on, and again, reduced meaningful engagement with civic space. So in that context, it can be very difficult to engage and negotiate in these processes. When it comes to issues of SRHR and gender, we know that that can be very contentious, and you see quite polarized views when it comes to member states discussing and negotiating this kind of language. We also have a very well-resourced and politically sick opposition that is actively funding the reversal of rights for people who are more likely to be in vulnerable positions, LGBTQI people. We've seen in the news lots of stuff going on right now around LGBTQI rights and women's rights globally. So it's a contentious time to engage, and it's a time where we really need strong civil society action and building strong consensus and engaging in really slick messaging so that people can rebuild the trust and understand the evidence when it comes to issues around gender and equity. Generally, the limitation of CSO, we're consistently fighting against limited CSO space and pushing partners and donors, member states to really ensure that CSOs have an active role in providing input into this kind of declaration, these kind of political processes. So I just want to finish by sharing with you two of Save the Children's recent reports on the Pandemic Fund and the Pandemic Accord, which has in more detail our messaging around pandemic preparedness, prevention, response. Thanks.
Thank you, Elo, for this very comprehensive account and on the Zero Draft, and also sharing the Save the Children efforts for influencing the language. Really commendable work. Thanks for joining and sharing these insights with us. I would now like to introduce and invite Jackline Kiarie. Jackline is a distinguished public health professional and a former member of the governing board of the World Bank Pandemic Fund. As a regional program manager, she exemplifies excellence in providing strategic leadership and technical expertise to the dynamic health security unit at Amref Health Africa. Her exceptional leadership skills are evidenced by her daily responsibilities, which entail forging robust collaborations with key stakeholders such as Africa CDC, ministries of health, and development partners across sub-Saharan African region to create and oversee innovative health programs that strengthen health security in the region. Ms. Kiarie's notable achievements include successfully spearheading the adoption of cutting-edge technology solutions and enhancing health systems performance, particularly in building the capacity of the health workforce in Africa, a feat that earned her the prestigious 2015 Brand Hall Award for Best Use of Mobile Technology Innovations. Thanks so much, Jackline, for joining us today, and I give it to you now to give us an overview of your work related to the topic here on the declaration, as well as please give us an overview of the African region context related to the negotiations and the pandemic process. Over to you, Jackline.
Thank you very much. And also thank you to Elo for all the really useful background that she's provided on this ongoing processes. So like she said, my name is Jackline Kiarie, and I work here at Amref Health Africa, based in Nairobi, Kenya, and our work cuts across most of sub-Saharan Africa. More recently, focusing on health security, the COVID-19 response, as well as the COVID-19 vaccination efforts. We've also played a major role on the ongoing conversations, trying to convene civil society to get the voices together to ensure that we can influence our respective governments to participate in the ongoing processes. Like you're all aware, we have the INB processes going on. We have the IHR amendment process going on. We have played a big role in the just recently concluded WHA, where, among other things, we convened ministers of health to try and get a common position on what they want to see in the INB, the pandemic accord, finally, and some of the amendments that we want to prioritize as a continent. So a lot of convening, a lot of trying to get a common position on the continent. We have our struggles, but we hope that by the time we get to September, then we're going to have the right input going into this political declaration. So glad that we are now seeing a lot more mention. We have been a bit more deliberate on the language that we're using, a lot of equity, a lot of gender sensitive language
Looks like we have lost Jacqueline. We'll just check with her and be back in a moment.
I'm just checking in with her now. Okay, she says that her electricity has been cut, so she's gonna try and join back as soon as possible. Maybe what we could do in the meantime is have some questions and responses to Elo's intervention, and then maybe we could switch back to Jackie when she's back. Sumegha, back to you.
Sure, thanks, Becca. I will open up to questions for Elo in the meantime. If you have any questions, please type it in the chat, or you can also unmute yourself, raise your hands and unmute yourself too. I'm observing the chat, but if you don't have any questions, you can also just share some quick comments if you have any on today's topic, or maybe share the work of your organizations and yourself. Quick thoughts. Rosemary, we can turn back to you.
So I think I can, not questions, but Elo's presentation was very rich, and I picked up a lot in terms of not only what is happening, but actually what needs to happen in the lead up to the high-level meeting. And I think the call to action that I heard from that presentation that include that we really need to rally ourselves and to continue to put forward a united front as communities and civil society in terms of influencing the language. So we have some wins, but we still have progress to make. And I think we really need to work on that momentum that has been created so far, which is really great. And the fact that it's, yeah. So, you know, like it's time to engage. That stood out for me in saying that there's no other time. It is now or never. So I think that's a really great rallying call to say we really have to have all our efforts together, and this is really the moment, because I think the update that, you know, the first revision of the document is currently being negotiated means that this really is the moment to engage, and that we need community and civil society voice. What I'm seeing, especially at the country level, when I reflect in my own country, is that there's quite a bit of community and civil society engagement on the TB high-level meeting, on the UHC high-level meeting. I think the PPPR one is the less popular one, but I think this is like a wake-up call, especially to also engage in low and middle income countries, to make sure that like the country delegations, the government delegations have these kind of messages even as they prepare to head out to New York for the high-level meeting. And so I think the call to action around us as communities and civil society, engaging government delegations and really exploring what are the opportunities and possibilities of having communities and civil society as part of the country delegation is really important, because then you can influence from the inside. So I think those were really great key highlights, and they stood out for me. I don't know, Sumegha, if you have any additional reflections.
Thank you. I'm generally so overwhelmed with this renewed focus, I would call it renewed, on putting gender and the gender language particularly. You know, we were earlier just talking about how women are missing, and I like that shift from women to gender and intersectionality, and that language gaining space in these documents. So that clearly is a development, and more to go. But I'll just circle back to Elo. Elo, we would like to hear more from you. We have one direct question from Tala, who's saying, what is it being done to shift financing to go directly to CBOs? How we were discussing about, you know, you talked about the role of CSOs, but for that we need financing. So are there any current efforts in terms of these financing shifting directly? And they say, seems to me this is a key area to focus on if we want systems change in global security. And I'll also just add another question for you, Elo, which is, if you can recap what a successful political declaration look like and elaborate on what Save the Children UK is hoping to see in the text.
Yeah, absolutely. I'll take the second one first and the first one second, that's okay. On what a successful political declaration looks like, I think we can think back to 2001 when there was a political declaration on HIV and AIDS, and that led to increased financing for the HIV/AIDS sector. It led to increase and sustained political mobilization, and then we were able to see impacts when it comes to mortality rates and so on and so forth. So if we could see in the pandemic preparedness and prevention response political declaration, those same actions, we can see sustained political action. You know, it's great that they have already, member states have already agreed to hold another high-level meeting in 2026 on the PPPR political declaration. It would be great then to see that there's been sustained engagement at the political level, meaning at head of state level, that there's been increased financing going directly to treat this, but embedded within UHC and PHC. So our concern in Save the Children is that we'll create, you know, these vertical funds that then don't go to the community level, don't go to health system strengthening, they go to these adjunct services that then are kind of parallel to the health system. So we want to see these funds and these mechanisms embedded into the existing health systems, working to strengthen existing health systems, particularly looking at community-based responses. So that's the second thing. And the third thing we'd want to see is that hopefully we'd had some impact, that when the next health emergency comes around, we see a better global response. I mean, we saw a fast response during the pandemic. We saw multilaterals mobilizing huge amounts of funds through ACT-A. We saw increased, you know, R&D going to the COVID vaccine, and it was incredible. But at the same time, we saw the powers, those who had the most power, accessing the tools more quickly. So we saw high-income countries vaccine hoarding. The UK was vaccine hoarding. We saw them having bilateral deals, intransparent deals, you know, where lower income countries kind of shut out of those processes. So we would like to see, you know, similar mobilization, similar partnership at the next emergency, but then a more coordinated, more equitable response where hopefully we don't see the same vaccine hoarding. We don't see higher income countries taking all the intel and preventing and, you know, being reluctant to share technology transfers to other parts of the world. So that for us would be a success. And the first question on financing, that's a crucial part of it. You know, I think CSOs are working to, well, Save the Children, we're working to ensure that governments actually put money behind this. And seeing that line in, I shared the slide on revision 1, where they talk about mobilizing the international community, mobilizing the necessary means to support Africa's efforts. I think that's a real call to action. That's saying that we want to specifically focus on the last mile or those left further behind. I think that kind of language is what we want to see in the declaration. We don't want to see that taken out. We want to see member states adhering to that and thinking that there's a need to recognize the value, the role that high-income countries can play. And secondly, I just want to say one thing which I hadn't mentioned before. There's a focus on brain drain in revision 1. They mention the fact that there's been this health personnel brain drain coming out of leaving developing countries and going to high-income countries. And for me, that's the first time I've seen that sort of language. Again, it's noticing that there's a duty of care here. There's a fair share that should be paid. And there's a recognition of like all the intersecting dynamics that cause health systems to be weak. And part of that is the brain drain. You know, and there's active personnel recruitment happening from high-income countries to low-income countries, where we have that health system, the value of those health systems being shifted over to high-income countries. So what are we going to do about those? So I think that kind of language is what we're really thrilled to see. And we see it as a shift from language maybe in 2019 in the UHC high-level political declaration. Over. I don't want to overspeak. Thank you.
No, this is so insightful, and certainly all these chronic issues that have been plaguing health systems for a long time are at least seeing some kind of awareness and getting some place on the agenda. We certainly, as you said, wouldn't want to repeat the mistakes of verticalization that we did with the infectious diseases and the HIV pandemic earlier. Now that we've got an opportunity, we would want to, create a change and not do the same with the health security agenda that we did with the infectious diseases pandemic in the 90s. And certainly the chronic issues of the power imbalances between the HICs and the LMICs and the sharing of resources. Indeed, it's very critical to have more equitable partnerships and breaking those imbalances. And the last mile point, I particularly liked how it's always kind of ignored, and all the supranational and the higher level issues are addressed in more of the international treaties and declarations. But the grassroots and the communities and the last mile initiatives are kind of ignored, which actually is the main and the more hardship areas and the points to address. And of course, the other chronic issue of the brain drain. But we have some more questions coming in. I wouldn't want to take much of the time here. We have another question in terms of how do you see the NY political declaration relate to the ones happening in Geneva? Where do you see these intersections happening? And also a question from Alison is, how can we frame global health security through a gender lens, particularly when it comes to improving security for the health workforce, considering so many of these initiatives are targeted at HR and their issues?
Yeah, great questions. I hope I can answer them. The first one on how is this linked to the INB negotiations? Well, the INB negotiations are actually separate and they're legally binding process, engaged in the INB negotiations going on with IHR. And we do actually have colleagues who are working on that. Our colleague in Geneva is very much engaged in those processes and attending where CSOs are engaged. But what we've seen in those processes, a limited participation of CSOs. So in some cases, we're being invited just to observe the very end of the meeting, the summary recap, not being shared documents and at early enough stage to do meaningful engagement. So we are seeing some challenges of civil society engaging. And even when you think about what civil society is engaging, we're talking about usually larger civil society at the global level, and we're missing that language and that access for grassroots civil society. I think that's something that we could all work to do, is to how do we ensure that we're giving space or sharing space with civil society that is at the local and at the community subnational level, which I think is still a critical challenge in our sector. And then on the question on health security through a gender lens, I think it's the thing that we have heard echoed since I think the pandemic started, which is this thing of if we're not consulted, we're not considered. So having lived those with lived experiences, being part of the planning processes, really making the effort to go that mile and get those voices at the table. Also financing to support engagement of those of civil society at the grassroots level, of women's groups, of gender leaders, giving them the funding to engage meaningfully. And also, when you just think about the architecture, getting a document 3 days before you are expecting comment is not meaningfully engaging. Like giving people more time to read through the process of feedback, having more flexible process of feedback so others can engage. I think there's lots of things we can do, but for me, one of the crucial things is if you don't consult the right people, if you don't consult people with lived experience, then we're going to create again a global health security architecture that is working for those who already hold power and isn't really working for those who are marginalized or more likely to be socially excluded. Over.
Thank you, Jackline. I have one more question, but I think Jackline is back. I'm sorry, I'm confusing. Thanks, Elo. So many back and forth, right? But there's one question on, does there appear to be much focus on the role of gender in upstream prevention? And maybe we can take after we hear from Jackline, and it could be open to both of you. Jackline, are you back? Can we hear from you now? Jackline, can you hear us? We'll give it another few minutes. Elo, would you like to address the question on the upstream prevention? And maybe we need a bit more clarity on the question from Rebecca. Yeah. Rebecca, would you like to elaborate on what you mean? Just if you could explain your question a bit more.
Hi, yes,
Yes.
Thanks. It's such an interesting conversation and fantastic to see the progress that's being made. I come from a One Health background, and so my interest is very much about preventing the disease spillover at source, so preventing the diseases actually entering into the human populations in the first place. And there is a huge role that gender has to play in that. If you think of women's roles in, food production and such like. So I just wanted to know whether there's much focus on, I guess, on the, upstream prevention or the prevention and source, and similarly whether gender is being considered with that. Thank you.
Yeah, that's a great question. Thank you, Rebecca. I think I understand more what you mean now. There's very limited language on animal health and the role of animal health and One Health as an approach, but there is recognition that an integrated One Health approach in the Political Declaration Revision 1 is one that would strengthen emergencies. So I suppose at the most top line level, there is recognition that that has to be an approach to support pandemic. So they've talked about, an approach that fosters cooperation between human health, animal health, and plant health, as well as environmental and other relevant sectors. So that's that thing of anticipatory action and looking at climate adaptations as well. So I hope that answers your question, but to be honest, there's not an intense level of focus on that when it comes to, and certainly not necessarily pulling those links in terms of gender in the declaration. Thank you.
Great, thank you. I think we're still waiting to hear from Jackline, but if there are any other questions or comments or interventions that you would like to make, all the participants, it's open to you. If you just want to raise your hands or just unmute yourself.
Maybe I can chime in here,
Yes,
Sumegha.
Rosemary, please.
Yeah. I think just it's unfortunate we've lost Jackline, because I think the regional perspective is also like very crucial in terms of what the African Union member states are doing and how we are going to make sure that this conversation includes perspectives and inputs of low and middle income countries. If you take Africa as an example, the African Union Commission, specifically the Africa CDC, is leading conversations on the PPPR discussions. And given that Africa negotiates as a bloc, it's very important for us in the region to actually sensitize and bring these kind of messages to both the Africa CDC as the lead for this, but also for the African Union member states. I think my assessment is that there's still a lot to be done in terms of sensitizing our leadership with the key messages that they need to hear before they go to New York or before they input into the discussions that are happening. I think the participation can improve, and I think that's the challenge for us. And I see many colleagues on this call who are from this region, and I think we have a lot of work to do between now and the high-level meeting to ensure that these specific asks, we put them in front of our leaders, we put them in front of the, like the Africa leadership team that is leading the conversation and the negotiation on this end. It's not just for the high-level outcome, the declaration, but it's also because I think we have to think about what happens post the high-level meeting. And I think for many low and middle income countries, the post is where we also lose it. So I think, the declaration is really important. It gives us a framework. It gives us an entry point for accountability. But the conversation we are having here is really important that our leadership gets to hear it, in the lead up to the high level meeting, during the negotiation, but also so that when we come back to the region and we are looking at national health systems, we are looking at how the health workforce is supported, is financed, then we can actually have an entry point for accountability. So I think just agreeing with everyone in the sense that we have to do a lot of work to put these asks, in front of our leaders in the lead up to the high level meeting. And there's a whole lot more that we need to do when we are back in the post high level meeting conversation and accountability work.
Sure, that's really important, Rosemary. And as Becca said, she got my question here, but do you see an appetite for these issues in the position in the Africa bloc? What elements do you think could gain more traction, and how do we go about it? Rosemary, do you think there is an appetite for the issues in the region?
I think the appetite is there. We are seeing so many countries really wanting to do something around the health workforce. We have seen many countries where, champions like members of parliament have tabled, bills in parliament on how to streamline community health workers, most of them being volunteers, and how to really put them in the mainstream, compensation structure of the country, within the Ministry of Health. That's, Kenya is an example of that, and many others. We've seen a loud voice, especially from parliamentarians, and I think that's an area we can do better in the lead up to the high level meeting and post, to actually build, more champions among parliamentarians to actually push the agenda. But I think COVID-19 has sort of elevated this health workforce conversation, particularly in our region, given the role of community health workers and the fact that the remuneration is not good, is not motivating. There are no incentives to actually get them to actually deliver and keep showing up at work, which is something we really need to think about and to protect. And if there's a way to raise the awareness and socialize our leaders during this moment, then I think we can have stronger conversations post the HLM.
Thank you, Rosemary. And I see the same initiatives kind of momentum gaining up in India as well, where our community health workforce, which was at the grassroots, the ASHA workers have been into pandemic preparedness and response and low remuneration or absent remuneration, and now trying to get traction around including them into mainstream workforce and train them further in terms of health emergencies. I have one more question, comment from Annie, who's asking if you were able to share any more on your experiences, and this is to Elo, in advocating this as a topic in global health security space. An obstacle I've found across my work has been perceived synonymity between women and girls-focused work with gender-focused work. Really important discussion. Thanks for bringing that, Annie, and over to you, Elo.
Yeah, thank you, Annie, for that question. And I think, I mentioned very briefly, I think I was already over time, but in the context where we're already seeing a rollback of rights for women and for LGBTQI people across the world, we're seeing this level of contention against even recognizing the most basic understanding of gender. So I feel like as civil society, we have a really long way to go to build the evidence, to bring people on side, to educate and engage. But from a health inclusion perspective, from a UHC perspective, it doesn't do anyone any favors to pretend that certain groups don't exist. And I think that's what certain leaders who are in the opposition would rather do, pretend it doesn't exist. But the reality of UHC is that you are trying to expand health coverage to everyone, and therefore you must count everyone. And I think that is Save the Children's Line when it comes to issues of going beyond the binary. I think it's just an obvious recognition, like whether you understand or you don't understand, the reality is these groups exist, people exist. There are LGBTQI populations everywhere. There are men who have sex with men everywhere. There's also, sex workers everywhere. And these groups need access to health services just as much as everyone else. So I think from an inclusion perspective, civil society really has the onus to educate, to just hold governments to account on what they have already committed to do, which is to, achieve SDG 2030 and expand UHC, and that's within the context of UHC for health. So that's just my response. I certainly think we have a long way to go, because we're already seeing a very slick, as I said, a very slick, well-funded opposition, in many contexts, advocating to push back on women's rights, advocating to push back on sexual reproductive rights, and advocating to push back on gender progression. So we have a long way to go, civil society. Over.
Thank you, Elo. Surely, and I just want to plug in a little to say that what has worked in our context in India and also globally is just naming the issues, calling them out loud. Sometimes language is so important, and calling them as it is and the issues as it is really helps in terms of building momentum and gaining traction. Confusing issues and combining them sometimes kind of take away the attention. So that has also happened in the leadership issues. Naming and shaming and calling it as it is could be one strategy to follow. But just one more question to both you and the moderators as well is, how can CBOs, CSOs plug in these issues and the processes in the coming weeks and months? So maybe we can start with Rosemary, if you want to highlight something, and then Elo, and then if there's something left that has not been covered, I'll try and plug into. Over to you, Rosemary.
Yes, and I'll start by, I've reviewed Becca's question, and I think I didn't answer the second part, which is asking what we are seeing from the African Union bloc in terms of an appetite for these issues. And I think that's where the challenge is, that the common position is coming up very slowly. So that's an area where we are engaging to see, whether we can have like really concrete position sooner than later. This evening, we have a meeting with the Africa CDC, and that's one of the conversations. But also, I think what we really need to do at the country level, especially because I think for me, that's where action is going to happen. And that's where the work following the high level meeting, all the commitments, we really have to happen at the country level. We really need to go and knock on the doors of the policymakers. We need to find out who is on the country delegation. We need to find out what is the country position on this high level meeting? What kind of messages do they have? But that's not enough. We really need to also engage like the missions in New York, like especially, countries that are highly impacted by these processes. So for those of you who have the opportunity to be in New York, knock on the doors of low and middle income countries as well. Submit the papers, submit the messages, and we can, I think, even have a coordinated approach where if you send a paper to the mission of Kenya in New York, we can, support that, with a letter to the embassy here or something like that. I think it's really time for action, and it's time to engage the national, delegation to New York and really have conversations. So I think for me, I would say national engagement and conversations really need to happen now. Sumegha?
Thank you, Rosemary. Really important. Elo, would you like to come in now?
I completely agree with what Rosemary said, so I don't have much more to add, but I do think that that's the best way, is to engage on delegations that will be in New York, that will be in Geneva, and we'll be negotiating these processes and knocking on the door and getting to know who's going to be attending and building that relationship and sharing that evidence. I think I totally agree with what Rosemary shared.
Certainly, and I agree with you both. Just adding that, I personally feel that traditional role of the CSOs being a watchdog of the governments, of the organizations, as well as the private sector, somewhere getting diluted. And now with the gained momentum for pandemic preparedness, we have an opportunity to, reassert that role and hold everyone accountable on their actions. And also the civil society in terms of raising the voices of the most marginalized and the people who are actually with their lived experiences, and being a platform for that could also be enhanced a bit more, and civil society has an opportunity there to work towards it. Well, this was great, and we had a wonderful conversation. I'll just give it to Rosemary to give the closing comments, and we'll send the notes and see you for the next meeting soon. Thank you for joining today, Rosemary.
Yeah, thank you so much. It's been a very, very rich conversation, amazing input. I really wish we had more time to just keep going, because you can sense the sense of urgency in the room, the sense of urgency of the moment, and that we have made some wins, we have made some progress, but still, I think the message here is that there's still a whole lot to be done if the outcome document is going to look much better in terms of accommodating the kind of asks that we have that look at gender within PPPR. And so I think well done to everybody who's been engaging, who's been reaching out, who's been providing comments. It's never, I think the HLM process is one of the most tedious processes, but one that we really have to engage, because if you don't engage, I mean, the declaration will still gonna come out, but it's gonna come out looking very interesting. And so I think for me is to encourage us to keep going, to keep knocking the doors. And there's so much context that has been provided here from Elo's presentation in terms of what we can actually do going forward. So Sumegha has mentioned that the notes will be sent out within a week. I think that would be very useful. The next working group meeting will be in September 12th, which really brings us very close to the high level meeting. So I think it'll be exciting to hear much more wins when we get together again on September 12th. And then just a quick announcement in that if you are a behavior change communications professional, or you are interested, or that's where your passion is, kindly join Pandemic Action Network's Behavior Change Communications Working Group. It takes place on Thursdays. It's going to be on Thursday, July 12th. It's going to be 10 a.m. ET, 3 p.m. GMT, 5 p.m. EAT, and I know it will be put in the chat so we can be very sure. So this has really been a great conversation. There's so much that we really need to do. We thank you so much for attending, for participating. We have taken note of the questions. Some of you have shared links, some of you have shared resources, and I know FIFA had also shared about a paper that is being worked on, so kindly feel free to reach out. I thank you very much, and I wish you a lovely day further. Thank you. Until next time.